Thank you very much. You may wonder why I've included this slide. It was just to reassure those who wondered what my day job really was. I'd like to start by thanking and again saying how well I thought the previous speakers had done and what a wonderful job they've done in covering absolutely every aspect of this talk. So you can sit back and relax and just refresh a few points as we go along. Trauma, of course, is a major health problem, as everyone knows, and there's a global increase in trauma. However, I'm pleased to say that in Victoria, the amount of road traffic trauma has decreased. Accident numbers are decreasing due to a number of initiatives. However, we are seeing more urban violence and social trauma. Putting it in perspective, it's always dramatic to say things like trauma is the #1 killer in those below 40, but when I show you a graph later, that's luckily because fortunately not many people die younger than 40. However, it is a very significant cause of morbidity and mortality, and as has been shown before, it is very expensive exercise. In Victoria, we're very proud of our state trauma system that was established with sort of ministerial backing, and it has had great effect on the outcome of trauma. As you know, it strives to meet the needs of all injured patients who require an acute care facility, regardless of the severity of the injury, where the accident occurred, and how few people in the area. So it's really is world class. When you reflect back on all the initiatives, it's really quite staggering, and I must admit I sort of thought that maybe somebody had made this slide up, but the reduction in road traffic fatalities that have occurred over the last 4.5 decades due to a number of things that you will all, if you reflect back, will remember happening. So that just shows that actually if you're going to spend your dollars wisely, prevention is usually generally more rewarding than getting into expensive medical interventions. Certainly since the introduction of the trauma system, that first slide was all trauma deaths, road trauma deaths. The second slide here is the in-hospital mortality following trauma. And you can see, unfortunately, that last blip just spoiled an excellent story. But there has been a steady and significant decrease in mortality. The aim of the trauma system was, of course, to try and encourage all those patients who require a sort of more resourced treatment to end up at a major trauma service. And you'll see by just looking at the figures at the Royal Melbourne Hospital, there has been a very steady increase in the number of patients who are receiving their treatment at that facility. So again, the execution of the service is working well. There are 3 pitfalls that I just wanted to ruminate over, and I think, as I say, these have been demonstrated, I think, in a number of the previous talks. One about the delays in management, secondly about the elderly comorbid patient, and then finally just a reflection on head injury, given that it's the #1 killer after road traffic accidents. Delays in management are clearly almost inevitable, and especially in a complex setting such as the management of trauma. To do it well and to do it quickly, we need to be prepared. We need all to understand what should happen when the patient arrives. We need a speedy way of deciding whether or not the patient needs to be transferred to a facility with more resources and what you do in the meantime. It was very illuminating, I think, to hear Graham Campbell's comments on, in spite of what I say, maybe the reality on the ground is not quite as it would seem. In terms of preparation, obviously at major centres there will be a standard team that will amass once the call's gone out. Far different in small, more remote rural areas, but the importance is that you need to know who is available, how to contact them, and when they do arrive to immediately designate them some specific tasks. The purpose of the initial assessment obviously is to identify and treat the life-threatening injuries, and this is the ABCs that everybody would have hopefully had some experience with, and then to go on to a secondary survey, making those important decisions as to whether or not the patient needs transfer. All of this is helped and facilitated by a series of guidelines that Trauma Victoria has established. These are available on the web, and they come in these very colourful flowcharts. Some of them are a little bit busy, but the better ones, I think, are well worth putting up on the wall in your resuscitation area, just to refresh new members of staff who may not be quite as familiar in the steps to go about looking after these trauma patients. The criteria that are set out here are those that are used at the roadside to try and identify people who most likely have major trauma, and it's based primarily on physiological parameters, but it does outline the high-risk mechanisms that would alert you. The idea is that if they meet those criteria, they are meant to go to a major trauma service if they can get there within 45 minutes. If not, they'll go to the highest resourced area service on the way. Reception, obviously when the people are all massed, their task is to do the primary survey and to treat any potential life-threatening threats. Again, there's this excellent flowchart that Trauma Victoria has made, which I think is really simple and gives some instructive help to how to go about doing this, and ending up with the question at the bottom should this patient be moved as quickly as possible, and how to go about trying to activate that process. And that is, as you've heard from Graham, that's Adult Retrieval Victoria are there to give advice and also to organise the transport platform for the patients. The major cause of delay at this stage is in transfer of the patients. There are guidelines that I've said that will tell you which patients should be transferred, but time does definitely slip away. And really since the time of the First World War, it was identified that delays are associated with increased mortality. The term the golden hour was coined. That's quite a clever way to put it. But in fact, it's not really a particularly golden hour. You don't sort of throw your hands up in the air and say, "Oh, sorry, our next one." And it depends on the sort of injury. But today we still use it a little bit, and it really means that window of opportunity to maybe save the patient's life. Now, that may be a matter of minutes if they've got an airway obstruction. It may be a matter of a few hours if they've got an increasing intracranial hemorrhage, or it may even be a matter of hours if it's an intra-abdominal, not bleeding, but some other intra-abdominal trauma that would eventually kill the patient. So delays will kill the patients. What do you do while you're waiting for the retrieval? Well, obviously, you need to get the patient ready. The last thing you want is for the retrieval to be slowed up because the patient's goods haven't been assembled. I think the important thing is that you don't necessarily have to do an extensive clinical workup with complex radiology in these patients. The task is to correct any immediate life-threatening injuries and then to determine if they need to be transferred. Now, that's easier said than done, and there will be some circumstances where you may need to do some more complex investigations in an urgent situation. But in most cases, a chest X-ray will tell you if you've got a tension pneumothorax, and the rest of it is securing the airway and resuscitating according to normal protocols. Retrieval, again, there are guidelines refreshing people on what the steps should be so that they're alerted to what would be needed to make sure the lines don't fall out, that the patient has been intubated when they should, that the chest tubes are secure, that the documentation is all amassed. These are all very helpful documents. The second area I wanted to talk about was the elderly comorbid patient, and there's a lot of documentation related to the increased risk that trauma patients in the older age group sustain. Older people are more likely to be injured and they have a higher complication rate and higher mortality rate than do younger patients, and that's usually due to their coexistent medical conditions. Not much nice happens when you get older, not the least even your selection in underwear. But Generally, unfortunately, our brains shrink, which makes us more vulnerable to the effects of deceleration injury with intracranial hemorrhage. Respiratory function decreases, so you're less able to tolerate chest trauma. Renal function also deteriorates, which may interfere with your ability to do some of the contrast-enhanced CT scanning, and most particularly decrease in cardiac function, and the effects of medications may make the patient's ability to cope with hypovolemia and blood loss. So how old is old? And you get a little bit of insight in that, but you'll see this was a sequence of events, and like a number of people, I've actually become frozen at a certain age down at that right-hand bottom corner. And I've decided that I'll use that in case my eyebrows go grey. The ageing process is relentless. The World Health Organization usually describes it at around about the retirement age in most countries, about 60 to 65, and that is said to be the beginning of old age. So, how big is the problem? And I think we're all bored with this. People are always sort of blaming the baby boomers for throwing us into total economic ruin. And you'll see from that slide, if you've got better vision than me, that the blue lines are the 2011, and the others were the 1999, that there were a high proportion of people in the older age group and fewer in the young age group. When you then look at the mortality, again, there's this dramatic increase in the incidence of deaths from trauma as you get to the older age groups. I got a little bit excited and thought once you get to 100, you no longer die of trauma, but then, of course, I realised, well, there aren't many people over the 100 who are there to die anyway. And again, just looking at the incidence of trauma, which I said before, people, as you get older, you become more susceptible to trauma. That's per 100,000 population. So the problem increases. And just to labour the point a little more than the 2010-2011, a third of the adult major trauma patients were greater than 65, fourfold increase in the 45 to 84 years, and a sixfold increase in the greater than 85. These patients are susceptible to what appear to be relatively minor mechanisms of injury, and falls predominate as the cause of major trauma in this age group. And these falls, of course, are a consequence of the ageing process, and these patients lead to significant hospitalisation. I think that's already been alluded to. However, it's not only falls that surprisingly 62% of the road users are greater than 65, and in fact 22% in the 75 to 80 years. So there are a number of road traffic accidents that occur as well. Not surprisingly, these crashes usually occur during the day. They're close to home, and often involve intersections where decision making is called. The other at-risk group are the pedestrians. It's not just confined to Australia, but here this is an American paper, as you'll see, showing that those greater than 65 have the highest population-based fatality rate for pedestrians. Now, they put all this down to the rate that older people can negotiate an intersection, which they call crosswalks, and 46% of all MPCs, that's motor car pedestrian crashes, fatalities, those in greater than the age of 65. So you've got to be careful if you're in America and hop it across the road quite quickly. Comorbidities, and everyone is aware of the high number of comorbidities that gradually creep up with us as we get older, and diabetes being the major one. So what do you do when there's a trauma team activation with the elderly patients? There's a risk that there may be significant under-triage, that the trivial mechanism may be not appreciated, the potential significance of the injury. Also, alteration of baseline vitals may be somewhat more difficult to interpret because the people may have been hypertensive. So a normotensive patient may in fact be somebody who has lost blood, and their slow pulse may be pharmacological. The triage guidelines here demonstrate again the importance of age as a factor. At the Royal Melbourne Hospital, all patients greater than the age of 65 who are admitted are co-managed by the trauma team and the trauma geriatric unit to try and address the increased complexity of these patients. Rib fractures are particularly lethal. I mean, obviously that's just a dramatic example, but even a single rib fracture in an elderly patient may be enough to unfortunately tip the balance. So, and the mortality increases with the number of ribs that are fractured. The message being appropriate analgesic and respiratory support is essential for the elderly patients. So we go into that. Head injuries, what would I say about that? About 65% of deaths are related to head injury. And Graham has already alluded to the difficulties that if you're dealing in a rural area in trying to drain any intracranial hemorrhage. So I think the main message is to try and minimise a secondary brain injury by avoiding hypoxia and hypotension. If there's a suspected head injury, then activate Adult Retrieval Victoria as fast as possible so that the hematomas don't increase. In modern times, the car accidents are a decreasing cause of these, with better car designs and probably with those blow-up bag things. But pedal cyclists and elderly falls have overtaken motor vehicle accidents. Particularly at risk, as Graham said, are those people who have their accident in rural areas. So with head injuries, anyone who has a moderate and obviously a severe head injury should be intubated to ensure there's adequate oxygenation, maintain the blood pressure around about 100 if possible, avoid hypotension. It is said that any single blood pressure less than 90 in someone with a head injury is associated with a 150% increase in mortality. If you want to make something sound dramatic, quote it in percentages. That means 1.5 times more in ordinary language. As I say, the thing to do is to try and avoid secondary hemorrhage. The major cause, and these were just figures from the Melbourne, relate to major cause of the severe fatal head injuries is something is far less dramatic, arising from low falls. These elderly patients, just reflecting back on those, unfortunately they can be a difficult group to manage. The injury can be a sort of sentinel event in their life and can change the total trajectory of functional decline. In other words, these people are already in a deteriorating generally, and the whole rate is reset, and only a small proportion of them return to their previous level of function and independence. So who are you going to call? I would, in spite of the difficulties that Graham's had, and I didn't realise that their helicopter, you have to go by an ambulance to get to the helicopter, but I think the best way forward is Adult Retrieval Victoria. Call them early, they'll give advice and they'll organise the platform. And again, I'd put in a plug for the very helpful trauma resources put out by Trauma Victoria. Thank you.